Let me compare Charlie and I. So my risk of diabetes compared to Charlie is probably about 50 times higher.
Oh.
Because I'm much older. But even if I was the same age as Charlie, it might be 5 times higher. The reason being, I've got a family history of type 2 and I'm South Asian. Being a South Asian, we put fat into the liver, a key organ for making excess sugar when the insulin isn't working as well, faster than white people do. Being a male, males put fat in the liver faster than females. Plus, I've got family history. Because my 2 uncles developed diabetes in their 30s, my dad in his 50s, my mum in her 40s, I'm genetically loaded. But the point being is, I'm more likely to develop diabetes at a lower BMI than Charlie. But the process is exactly the same. It's just that my genes, my makeup, the fact that I'm male, means that I'm putting that fat in the key organs that are relevant to sugar much faster than Charlie would, for example.
This is The Method, a podcast from Thriver about what health looks like in the real world.
I'm Dr. Greg Potter. I'm a scientist and health and performance consultant.
And I'm Charlie Edmondson. I'm definitely not a science expert. I've got a regular job and I'm here to remind Greg of what life's actually like when you're not a nerd.
You must be a nerd about something, I bet you are. On this show, we'll work out some sustainable changes to your routine that are actually going to make a difference to your health. And to do that, we have a simple 3-step method. With the help of an expert, we first unpack the science behind one key health question. Second, we give some recommendations related to what we're speaking about on the day. And then finally, we put the practice to the test.
Each week, we're going to hear from those who have tried and tested our recommendations to help turn a so-called ideal lifestyle into something that actually works for you.
Giddy Charlie,
Oi.
with your enthusiasm.
Excuse me.
That big beaming grin.
Turn my camera off. How are you?
Oh, you first.
I'm good. I'm refreshed after my 2-week holiday. First time I've ever taken 2 weeks off in my entire working career. And
Wowza.
I think I could do it more often, I'll be honest. Had a wonderful time.
Where did you go and what did you do?
I went to Canada for 2 weeks. Well, Vancouver Island, went hiking and kayaking and surfing and camping.
So it's very passive.
Yeah, a lot of people say to me, like, do you not need a holiday after your holiday? But being on a different time zone and then not having much signal, absolute dream. No one speaks to you. It's great in the nicest possible way. I can see why you love the nomad life so much.
I can't imagine you ever just lying by a pool.
Maybe for like
No.
2 hours, 3 hours, I could do it.
Yeah.
But then after that,
I can't do it.
no, it's not for me. But yeah, back to reality.
You got a song for us this week?
Oh, sugar, sweet, what's that? Sugar for my honey, sweet, sugar, but that's a good one. What's the lyrics?
There we go.
Sweet, sweet, honey, sweet, sugar for my honey. Let's go with that's the lyrics.
I'm impressed, as always. This week, we are discussing diabetes and specifically type 2 diabetes, which is a very common problem. Going by a recent estimate, it's thought about 6% of people worldwide have diabetes. And that's about double the proportion of people that had it in 1990.
Oh, really?
Yeah, it's on the app. And a lot of people that have it have no idea that they have it.
I actually know someone who's got type 1 and a few people with type 2. Type 1 is quite restrictive on your life, isn't it? Whereas the people that I know with type 2 diabetes do tend to have a sweet tooth and love chocolate. I also knew someone who got it during pregnancy, which I probably wasn't really aware of, that was such a risk factor.
There are lots of forms of diabetes. There's type 1, there's type 2, there's gestational diabetes, which is what you're referring to there. And people also refer to pre-diabetes. So you can go from otherwise being healthy to having pre-diabetes and then to having type 2 diabetes. And even within type 2 diabetes, there's quite large variation between people and some of the symptoms they experience. Type 2 diabetes, which we're focusing on, accounts for about 96% of cases. So it's really very common. And part of the problem is that it's associated with lots of other health repercussions. People who have diabetes have a much higher risk of various cardiovascular diseases. And that includes problems with the heart, stroke. They have a higher risk of various different kidney disorders and peripheral artery disease too. So it comes with a big burden. But the key is that many cases of type 2 diabetes are preventable. Arguably, a lot of them are reversible as well, because nowadays we actually have quite good treatments. So Charlie, what do you know about the risk factors for diabetes? You mentioned having a sweet tooth. So that suggests that maybe nutrition is one of those risk factors. Any others?
Risk? Do you mean as in symptoms or risks?
No, I mean things that people do that are going to influence their risk of developing the disease, but also demographic factors. So, for example, do you know if men or women have a different risk of the disease?
Oh, gosh, you're testing me here. I don't actually know. I think weight, being overweight, I'm assuming then being inactive is a bigger risk. Is it genetic? Are you more prone to it genetically?
Yeah, there certainly is a genetic contribution. And within genetics, obviously, your genetics determine your biological sex. And interestingly, the most recent data from 2021, looking at lots and lots of people, suggests that the male to female ratio is about 1.14 to 1. So men have a greater risk than women do. And I'm sure we'll get into that in the episode with our guest today. So who is our guest?
Professor Naveed Sattar, who is a professor of cardiometabolic medicine at the University of Glasgow. Naveed is one of the world's leading researchers in diabetes, obesity, and cardiovascular disease. His work has helped shape how we think about weight in preventing and treating type 2 diabetes. He also works closely with patients and is known for making complex science much easier to understand. So fingers crossed for me that he's going to do that. Naveed is also particularly interested in how we apply research into the real world. He's openly spoken about his own increased risk of type 2 diabetes and how this has influenced his decisions he makes about health.
So it's nice to have someone who has deep expertise in the subject, but also practices what he or she preaches, because I think people like that are better able to empathize with people who are going through process of trying to reduce their risk or trying to treat the disease. And him being a medical doctor too, he'll also understand all the pitfalls of this condition and the challenges that these people face in a way that a lot of people who are pure academics might not.
Yeah, amazing. Shall we bring him in?
Yeah, let's go for it.
Hi, Naveed. Welcome to The Method. How are you today?
I'm very well, Charlie. Nice to be here.
Well, so we're just going to start with the basics. So what actually is diabetes and what's the difference between type 1 diabetes, type 2 diabetes and gestational diabetes?
Okay. So diabetes is a condition where the sugar level goes above a certain level. In medical terms, we use what's known as hemoglobin A1C or glucose levels. And what happens is when the sugar goes above that level consistently, it starts to cause damage to some of the small blood vessels in your body, and it seems to stick to proteins. Type 1 happens because the hormone that we require to put sugar in the right places to store it when we don't need it, or to help put it into cells we want to burn it to make calories or to make energy, is insulin. If you cannot make insulin, then guess what? That sugar stays in the blood to very high levels and can cause huge amounts of damage, which is why people with type 1 diabetes are treated with insulin. Type 2 is completely different. Often you can make enough insulin, but what's happened with type 2 is that you've put on weight, and that excess adipose tissue or fat gets into the liver or into the pancreas, which makes insulin, or in the muscles. And what happens then is the cells in the liver and the muscle, if you have too much fat, don't respond to the insulin in the way that they should normally do. And if you put too much fat in the pancreas stops not making enough insulin. So effectively, what we've realized now is type 2 diabetes is the disease of ectopic fat, i.e. excess fat in organ systems, which then disrupts your sugar metabolism to keep your sugar higher than it should be otherwise. So they're completely different mechanisms, which is why the average age of type 1 diabetes is about 14. And it's because something has attacked the pancreas to stop body making insulin. It can develop at any age, but the kind of median age is 14, whereas type 2, because it's linked to older age and obesity, is about 50 to 60 on average. They're quite different. So pregnancy is what's known as a metabolic stress for women. When the mother is developing a growing fetus, she has to develop a placenta. She has to put a lot of resources to making a placenta and a fetus. And that means she has to move lots of energy around in different ways, which is stressing her metabolism. So most women undergo that perfectly fine. But if you're carrying a bit of excess weight or you have a higher genetic risk for diabetes, that stress of having to shift lots of fuels around in different ways can lead some women to develop diabetes because it's stressing the system. And once you deliver, that stress actually goes away. So gestational diabetes is effectively, it's a stress test, and it unmasks women who are at future risk of developing diabetes by putting them under a stress during that period of 9 months. And lots of women who get gestational diabetes will develop diabetes sooner in later life because it's marked those women as those who are at high risk of future diabetes. That's what it is. The issue now is that in the UK now, say 50 years ago, maybe 1 in 100 had gestational diabetes. Now it's 1 in 6 pregnancies in the UK is affected by gestational diabetes.
Oh gosh, that's quite high.
We're focusing on type 2 diabetes today because it makes up so much of total diabetes. Recent estimates suggest something like 96%. It's clear that when you get glucose sticking to tissues and organs that we'd rather it didn't stick to, there's dysfunction that follows that. And associated with diabetes is an increased risk of things like cardiovascular disease, kidney disease, and various other pathologies. We don't want to fearmonger though, but it's clear that there is a genetic contribution because it does tend to run in families a little bit. However, maybe some people might overestimate the extent of the genetic contribution. And there are lots of risk factors that are at play, including things like demographics, like how old someone is, their biological sex, their race, but also lifestyle factors. So it would be great if you could put this into context and speak a bit about the biggest risk factors.
That's a really nice summary, Greg. So let me do it this way. There's the three of us here, but let me compare Charlie and I. So my risk of diabetes compared to Charlie is probably about 50 times higher.
Oh.
Because I'm much older. But even if I was the same age as Charlie, it might be 5 times higher. The reason being, I've got a family history of type 2 and I'm South Asian. Being a South Asian, we put fat into the liver faster than white people do. Being a male, males put fat in the liver, a key organ for making excess sugar when the insulin isn't working as well, or if you put too much fat in the liver, that stops the insulin working as well, faster. Males put fat in the liver faster than females. Plus, I've got family history, so that means beyond just my ethnicity, because my 2 uncles developed diabetes in their 30s, my dad in his 50s, my mum in her 40s, I'm genetically loaded. And that's partly because of where I put my fat, and there might be something else going on, but predominantly fat. The point being is, I'm more likely to develop diabetes at a lower BMI than Charlie. Charlie might need to get to a BMI of 40 to get type 2. I probably can get it at 26. But the process is exactly the same. It's putting fat in the liver, ectopic tissues that will eventually trigger it. It's just that my genes, my makeup, the fact that I'm male, means that I'm putting that fat in the key organs that are relevant to sugar much faster at a lower BMI than Charlie would, for example. And that's what it is. So each of us has a different gradient for when we put fat for a given weight gain, for when we put fat in the wrong places where it can cause increased risk of diabetes. But the trigger, regardless of where that gradient is weight gain. The average man needs to put on less weight than the average woman, and the average Asian needs to put on less weight than the average white person, as an example. That's the way it works.
I just want to spell something out, which is the term ectopic fat. That is basically fat where we don't want to have fat.
Yeah.
So in organs like the liver, the pancreas, skeletal muscle, and so on. So what we're speaking about here really is a kind of central obesity, which is what dramatically increases risk. And there's this concept that was put forward by a colleague of yours who I imagine you know well, Roy Taylor, years ago, the personal fat threshold. And the idea is that each of us has this personal fat threshold beyond which we start to quite quickly run into metabolic problems. And that varies a lot between people. So if you look males versus females, factors like age, older age being a risk factor, race, anybody who is non-white relative to a Caucasian person has a higher risk associated with weight gain.
It's exactly that, yes. It's like your characteristics set your gradient for how quickly weight will lead to metabolic harm. As an example, the reason I knew that I had a very strong risk is that my two uncles on my mum's side developed diabetes in their 30s and their BMIs were around about 25. Almost normal BMI for white individuals. And that's even more accelerated than the average Asian as well. And I thought, oh my goodness. And then my mum, who obviously women have a lower risk than men, she developed diabetes in her 40s. So that's the way I realised it. And younger people need more obesity to tip into diabetes than older people. If you look at both of you, you both are young, you both got very good muscle mass and your pancreas is younger. So you're able to make lots more insulin and you're able to burn more calories and to burn more sugar in your muscles because you've got bigger muscle mass. So you actually need more disruption of that system. You need more weight to flood into those organs to tip into diabetes. And that matters because we now know that younger onset type 2 diabetes is a lot more pathogenic and harmful than diabetes developing at 70 or 80. Now, if I develop diabetes eventually at 70, I don't care, actually. I'm not too worried. A, I'm not going to live long enough for it to cause enough harm in my eyes and the kidneys. B, I also know that developing diabetes at older age, if you look at lots of epidemiology, the sugar is going up more slowly because it's a slow process to have got there. Whereas if you develop diabetes in 20, it's associated with much more weight gain, much more rapid sugar rise because you're putting fat in the wrong organs faster. And because the weight is higher, you've also got much higher blood pressure compared to your age. You've also got higher blood fat levels. And all of that begets faster damage to your key organ systems, your eyes, your kidneys, your liver, your heart, and so on and so on. And the way we illustrated this was looking at life losses. If you develop diabetes at 30, the average life loss in a white individual is about 15 to 20 years.
Wow.
If you develop type 2 diabetes at 70, it's maybe 1 to 2 years loss of life.
You've spoken about how the modern environment can increase our risk of developing diabetes, sometimes through things that are completely out of our control. What are some of the features of modern life that are contributing to that risk?
Well, I think it's something, Charlie, I think we all probably know them. It's over the last 50 years, so in 1950, 1% of the population were living with obesity. In 1980, 6%. In 1980, 1% of the population had type 2, and now it's about 8 to 9% in the UK.
Gosh.
In some countries, it's 20%, which are the countries where they put fat more centrally faster, like Asia, or in the Middle East as well, where food industrialization and activity levels have substantially been altered in a really adverse way. So there's far too many calories in society. You walk down the average high street, you can get multiple calorie sources. And of course, commuting to work has gone down. The capacity to be physically active has diminished. But beyond that, there's other factors as well. I think people have not recognized this thing. The humble iPhone, I think, is making life more obesogenic.
Yeah.
What's the last thing most people do at night? Oh, I'll just check my emails. Or I'll just look at something, social media. And guess what? You're stimulating yourself and you're not going to sleep properly. And sleep affects appetite. So basically, technological advancement improves lives, but it does make us less physically active. It does distract us in ways and stops us giving us better sleep and stops us giving us space, resting our minds. And also the capacity to buy calories or even have them come to you is seducing people who are vulnerable to overeating to eat too much. And that susceptibility of weight gain is partly genetic. You two are looking really lean and healthy, so you're lucky. You've got probably good appetite genes and you've got good life circumstances. The average person that I see in my clinic who's living with obesity, and particularly those who've been overweight all of their lives, either they've obviously got a set of genes that means their appetite control is not as good. So for a given food environment, they're going to be seduced to eat more. And or they've had psychosocial stress in their life that further compounds their lifestyle, and or they live in an area where there is more fast food and less healthy foods. And or they've got parents that are living with obesity that are giving them more foods. and so on and so on. And guess what? Obesity is going up fastest in the poorest parts of society. It's also now, we're at a point where the environment today is much more obesogenic than it was in 1990, than it was in 1970. And guess what? Guess where obesity is going up fastest? In the youngest and the poorest. And it's also going up fastest in certain people who are more susceptible. So this is not predominantly about willpower. There's multiple dimensions to this.
Thanks for that, Naveed. You've really done a good job of explaining many of the factors that are at play. Before we move to the practice section, I just want to try and briefly summarise what we've covered so far. The main forms of diabetes are quite different from each other, but within them, type 2 diabetes is by far the most burdensome at the level of the general population. Type 2 diabetes is fundamentally a condition of insulin resistance, and that's driven by a range of factors, but within those, high body weight is a particularly important upstream factor because at some point, weight gain leads to deposition of fat around organs and inside organs that impairs their function, so-called ectopic fat. Some of us are at much greater risk of diabetes than others. In particular, people who are male, older, and who are not Caucasian are at higher risk. And the problem is that nowadays, a lot of us live in a very obesogenic environment. That's especially true of people who are less well off. And unfortunately, a lot of those people have less access to some of the therapies that are maybe most potent. However, we are not doomed because if we can target the excess fat mass, then we can not just halt the diabetes disease process, but in people who already have type 2 diabetes, there's evidence that we can actually reverse it. And some of studies by yourself and others have shown that there's probably improvement in pancreatic function too. And that suggests that there's actually restoration of the tissue that is damaged and at the core of the diabetes disease process. So body weight is key.
Can I just, in terms of the evidence base for reversal, the better evidence is actually reducing liver fat, Greg, than pancreatic fat.
Okay. Yeah.
I think the pancreatic fat imaging is very hard and there's still a little bit of debate. I think probably is relevant, but if you cut the amount of fat within your liver from 17% in the average diabetes population down to 3%, guess what? That liver then beautifully responds to the insulin you make to cut down production of sugar when you don't need it. Mm-hmm. That's what happens.
Thanks for the intervention. That's helpful.
Yes.
And that brings us to the practice section. Charlie, over to you.
So now we're going to move into the practice section of the podcast. So Naveed, you've spoken openly about having an increased risk of type 2 diabetes yourself. Knowing what you know about the disease, has that changed the way that you think about your own health and the habits that you've built?
Yeah, no, absolutely. So knowing my family history, there was a study that was ongoing where they took 300 blood samples from 300 people and measured various things and metabolism. And the researcher came back to me and said, Naveed, I'm sorry to say this, but your insulin level is the highest of everyone. Oh. That basically meant that my pancreas was working really, really hard to keep my sugar normal. And I was probably about 1.5 stone heavier in my 20s and 30s as a junior doctor running around and not eating so well. You know, we had family, we had kids, and, you know, your ability to be active, obviously, when you have kids is diminished. So when I got to about 40, it became evident that my family history was even stronger. It wasn't just even in diabetes, it was in cardiovascular disease. So I was starting to think, I really need to improve my health. I got into biking and cycling, just as you have in Charlie. And so for the last probably 15 years, I've commuted to work on the bike. I go cycling every weekend with friends. Anytime I give an opportunity to bike, I'm good. So I'm lucky. I've got that agency. You know, I bike from a young age. I'm able to afford a really nice road bike or a gravel bike. I'm able to store it properly. I'm able to put it into work and have a shower. I've got all of those agencies. That helped me. And the other thing we got 10 years ago, we got a dog for the same reason that kids wanted a dog.
I would strongly recommend everyone does get a dog though, Naveed.
Yeah. So my step count probably went from an average of about 5,000 or 6,000 and now I'm doing about 11,000 a day, you know, and I'm approaching my 60s. And my muscle mass is great. My HDL is a biomarker of activity. It used to be 1. It always tends to be low in South Asians. Anyway, so by that process, I'm still in the pre-diabetes range, but I'm still at the very, very bottom of that. So I'm likely to get diabetes, but probably when I'm 70.
Right.
I probably delayed it by 30 years compared to my uncles, by 20 years compared to my mum, by 15 years compared to my dad. And as I've said to you, If I get diabetes at 70, I'm not really that worried, because the damage to eyes and kidneys and other, it probably won't happen because we've got better drugs by then anyway. But again, this is not to say I'm better than other people. I'm not. I have been lucky. I've got that ability. I've got that understanding. And I've got all these opportunities around me because I live in an affluent area. I've been educated and all these things. What we now need to do, and I don't have the barriers, we need to help other people overcome barriers to be more physically active, to enjoy physical activity, to eat better. The other thing I've learned to do is actually, as part of my eating, I always try and bring a piece of fruit to work. And I didn't do that 20 years ago. And I've retrained my palate to enjoy more fruits and vegetables. I still have some chocolate, but I have half of what I used to. I've retrained my palate to enjoy more fibre-rich foods. I have people in my clinic who never really eat salad. It's not their fault, but they say, oh no, I'm repulsed by that. Well, they've never really tried it. It's those small tips that we need to help people with, because what happens is in clinics, we give them booklets or we give them diet sheets. Do you know where that goes mostly? In the bin. Enough. It's not enough anymore to say, Mr. Smith, you're overweight. Come back when you're 5 kilograms lighter. Well, for frick's sake, if you knew how to do that, you would have come back.
Yeah, he wouldn't be sat in your office.
He wouldn't be sat in my office.
Yeah, thanks. Really helpful.
Do you think he wants to be a BMI 32? Come on. So we have to have lifestyle advice much simpler. We're developing something. I think we're going to do it in Scottish Government, which is going to be then go out to all clinicians in Scotland. 3 or 4 of my colleagues in NHS and primary care love it. They said, this really helps. We explain people how to eat less calories, what the simple tips are, and we give them the agency to fail to try one of those things. So that's how we need to improve the lifestyle part. I think we've improved, but we can improve it a lot further.
If we speak about screening and testing, which you've already mentioned, Naveed, you touched on screening very briefly early on. If someone listening thinks that he or she might be at increased risk based on some of the things that we've spoken about so far, is there a free screening tool that you would recommend? And then secondarily, when it comes to testing, you've spoken there about things like HbA1c. You also mentioned HDL. Both of those are available through Thriver if people want to get tested at home. Which tests do you pay most attention to clinically when you're trying to get an overall assessment of somebody's metabolic health and risk?
Again, it's a great question, Greg. So for the vast majority of people, I think hemoglobin A1 is really good, actually, because it's an average of your sugar levels over the last 3 months. And diabetes is when hemoglobin A1 gets a level of 48 millimoles per mole is the kind of units we use. Pre-diabetes, so you're at risk of diabetes in the UK, is when you're 42 to 47. And normal sugar levels are below 42, so 41 and under. So hemoglobin A1, and it can be done at any time of the day, whether you're fasting or non-fasting. And I've helped change the guidelines to remove the need for fasting for lipids as well, because most of the lipids that we measure are pretty accurate when you're non-fasting as well. The other thing we measure is often liver function, because one of the liver tests called ALT, which is basically, it's an enzyme that's produced within the cells of the liver, and it goes up when there's too much fat within the cells of the liver. So ALT, triglycerides, so lipids, liver function, and hemoglobin A1 is the kind of 3 tests that we commonly measure in the clinic. If someone is out there worried about their diabetes risk, they can go online first, Greg. They can use the diabetes risk score from Diabetes UK. There's also what's known as a Q diabetes risk score. It includes things like maybe some drugs that you're on, and that's available online. And then if you do that diabetes risk score and put in a few factors and it comes up as moderate high, you can go to your GP, or you can go online, as you say, get some other and tell your GP, listen, I've got this high diabetes risk score. Would you please measure my hemoglobin A1? It should be an easy test to do.
I know we briefly just touched on your cycling habits to help with your higher risk of diabetes, but what about exercise to prevent and manage diabetes for other listeners? Do you think there are any key types of exercise or goals of exercise that people should pay attention to?
So I don't even like the term exercise anymore, but actually that's not true. I'm changing my views slightly. So there are barriers toward using the word exercise to lots of our patients, right? 3 of us have got huge agency. Charlie, you've got beautiful bikes behind you.
Thank you.
Greg, you look fit and athletic. But listen, I see patients who are in their 30s who have obesity, psoriasis, sleep apnea, who are not working, who are demotivated, who are depressed. You know, depending on where people are at, the key thing is, can we help them work out what the barriers to physical activity?
Yeah.
How many steps are they walking a day? And if so, can they increase the number of steps even by 500 a day, which equates to 5 minutes extra walking? Can they measure it, start to measure it systematically so that they know what they're doing? And can they use that as a biomarker, which is what I do? If I look at the end of the day and think, oh my God, I've only walked 4,000 steps, and I did that a couple of days ago, I better go and do another walk, put my podcast on, or maybe take the dog for a walk. You know what I mean? Just consistent activity is really good. So just giving people to say, look, how would I get more activity? Well, just maybe walk a bit more. Maybe is there a friend that you can join a walking club? Instead of taking your car to the shops, it's only 15 minutes walk. That'll get you 1,500 steps. And if you do it back and forth, that's 3,000 steps more. That's fantastic. That's about 120 calories that you've burnt. Explaining the way that people resonate.
Yeah.
Or maybe get into habit that after your main meal at night, rather than jumping in front of the TV, to develop that habit, okay, I'll go for a 10-minute walk around the block. It's those kind of things. Once they've achieved that, I completely agree. Exercise is important. If you can get to a point where you're a bit fitter, maybe you could then start thinking about find an activity that gets your heart rate going a little bit. Because as you put your heart rate up, you're making your blood vessels more pliable, pushing blood through your blood vessels, and you're keeping your pumps and your pipes and your filters more efficient, is the way I try and explain it. So how we explain these things to people really matters, I think.
And on that note, I think something people miss who maybe don't share some of those features is that exercise can be really aversive for a lot of people. And it's very different if you are carrying a lot of body weight that you have to lug around. The amount of inertia that's involved is nothing like what the three of us here experience.
100%.
And so sometimes, rather than starting with exercise, it makes sense to actually start with something pharmacological, a drug, medication, that can help kickstart the process. And then if somebody can lose weight first, they start to adopt healthier lifestyle habits because they become less aversive. So on that note, when it comes to type 2 diabetes, how do you decide which medications are best for a patient of yours, as well as when to start said medications? I realize that this is a massive subject, but I think it's worth just...
Well, no, I can summarize it really easy, Greg. The simple summary is the following. 15, 20 years ago, we had drugs that lowered sugar, didn't often lower weight by very much, and very few of them affected major outcomes. Now we've got two classes of drugs. One that seems to get rid of excess volume in the system, which is the SGLT2 inhibitors, and they lower sugar, and they protect the pumps, pipes, and filters. And they're now almost first line in diabetes because they really reduce the hard outcomes. And they reduce sugar in diabetes, and they help a little bit of weight loss, 2 to 3 or 4 kilograms. The other class is the incretins, or weight loss drugs. And they're now being used much, much more because it's targeting the primary cause of diabetes in the vast majority was ectopic fat, excess weight, and led to ectopic fat. So those that used to be third or fourth line, after insulin, with insulin, now before insulin, now they're starting to become almost first line in some countries. In fact, they're too expensive to be first line, but the new guidelines coming from American diabetes and European diabetes are likely to push them much higher up in their algorithm. Why? Because if you help an individual reduce that food noise, which is what these drugs do, cut the caloric intake by 200 to 400 calories, lose 15 to 20 kilograms, reduce your liver fat from 17% to 3%, guess what? Their sugar levels normalize or get much better. And you reduce their blood pressure, and you improve their blood lipids. And what we didn't anticipate, the drugs also seem to have direct effects in slowing up blockage of your arteries as well, protecting your kidneys. So if we could afford it, if these drugs were really cheap, they would be first line everywhere in the world for type 2 diabetes. So it's a huge revolution. And they are now first line in a group of people with young onset type 2 diabetes because nothing else really touches them. But if you could tackle the weight and the food noise in people who've got a BMI of 40 at the age of 25 with type 2, that's the way to treat the diabetes in that individual who's got the highest risk of the worst complications. Because guess what? It's the obesity and the food noise, that's the primary culprit leading to everything else for that individual. That's where we're heading.
Let's just hope that the price of them continues to come down.
Yes, absolutely. And the safety elements continue to be good. And you made a really important point. People living with obesity are not greedier or lazier than other people. Obesity, if you're carrying excess weight in your arms and legs, it's much harder to move. And my colleagues actually proved using genetics, being heavier leads to lower activity levels. So once you're on these drugs, what we need to do is help people overcome barriers, and they've lost 15, 20 kilograms, is to them imagine a new life, to either re-engage in activity they did when they were 20 years younger, or to find new activities to capitalise on that way that they feel, the new weight that they're at, to give them an even greater improvement in their quality of life, if we can.
Charlie, sing the sentence.
Before we move on to the next section, just a quick break to talk about Thriver.
That's got to be used.
God,
We have to use that.
it was so good.
So what is Thriver? Well, it's a platform to support healthy longevity. It provides at-home blood testing that helps you understand what's going on in your body. And with their tests, you can establish a baseline for your health and take steps to sustainably improve it.
You order your test online, do it at home, post it back, and within a few days, you get your doctor's report explaining where all your levels are. We've done it, and I can confirm it's super easy to do at home. Also, I'm a picture of health and have more vitamin D than Dr. P.
Yeah, not anymore, mate. Sorry about that. So if you're interested in learning more about your health, or you just want to show off like Charlie does all the time, you can order your kit online at thriver.co.
That's Thriver with a .co.
All right, should we get to these questions then?
Let's. So we now move on to the experience section of the podcast, which is where we're going to put some listener questions to you, Naveed. So the first question is from Helen in Norfolk. And she has asked, I have a family history of type 2 diabetes and had gestational diabetes during both my pregnancies. How does this affect my risk factors for type 2 later in life? And is there anything I can do to prevent onset?
So if you've had gestational diabetes, the policy in the NHS is that you should be checked regularly by your practitioner for diabetes risk. So she should, if she's had gestational diabetes through pregnancy, that individual should get her hemoglobin A1 checked by the GP to know where she's at. And it might be that because she's now fine and she's lost weight, and she might have had a much bigger rise in the metabolic risk during pregnancy than most, it may be that her hemoglobin A1 is normal, in which case she can relax a little bit. Or it may be that she's got pre-diabetes, in which case she can get a sense of what weight she's at, what's her hemoglobin A1, and how much weight she needs to maybe lose to reduce that risk, or how urgent is that risk for diabetes. Because if the hemoglobin A1 is like 46, she's close to developing diabetes, then that's a reason to perhaps think about lifestyle and reduce weight by 4 or 5 kilograms. Or she may have undiagnosed diabetes, in which case then clearly. So get the hemoglobin A1, because that is the measure that tells that individual where they're at in terms of diabetes risk.
The next question is from Richard in Edinburgh, and he has asked, I had a HbA1c that crept up to 67. However, after starting on Mounjaro, it dropped to 31. I've since, 8 months ago, stopped Mounjaro and it's heading back to around 40. Would you recommend restarting on a low/maintenance dose?
So that's an individual choice. So what's happened there is exactly what you would expect. With tirzepatide, which is this proper name, Mounjaro is obviously the name that Richard and many of the listeners and all of us will hear in the media, has shown evidence in people living with obesity that if you start Mounjaro and you've got pre-diabetes, it reduces the risk of developing diabetes by 93%.
Gosh, that's huge.
That tells you it's huge, exactly. And the 7% who did develop it probably had a different form of diabetes. Maybe the insulin wasn't working as well. So the answer is, if Richard is willing to pay for that and he wants to not get diabetes, the answer is yes. If he stays on Mounjaro at a low dose, he's likely to keep his sugar levels down. The reason the hemoglobin A1's going back up is he's probably putting weight back on again. So Mounjaro is working in two ways to keep his diabetes, to improve the sugar. One, big weight loss, getting rid of fat in the liver and so on and so on. And two, the incretin, which is what the drug is, also helps the pancreas make more insulin. So it's got a direct effect on sugar because of the molecule that helps the pancreas make more insulin, and an indirect through weight loss. And what I've written a paper recently that says we should be using these drugs right at the diagnosis to reverse diabetes, exactly as Richard has done. And if you keep on that drug, he may be able to delay his diabetes by 10 to 15 years. And that will reduce his future risk of many complications.
Thank you. The next question is from Ali, and they have asked, I'm South Asian and I have a family history of diabetes. I had gestational diabetes 3 years ago. My HbA1c is 32, which is good, but my fasting glucose level is 5.9 to 6 on waking. My GP isn't concerned and said he will help if the fasting glucose gets higher, but I don't want it to. I'd rather act now. What can I do to help myself now?
I would just reassure Ali, the hemoglobin A1 of 32 is completely normal. I would get that rechecked just to double check that's accurate. We have published papers that show that in South Asians, and not actually generally in whites, but it applies for many, that hemoglobin A1 is the best marker for the complications of diabetes. And 32 is so far away from diabetes, which is 48. I would be delighted if I had a hemoglobin A1 of 32. And fasting sugar is neither here nor there. The hemoglobin A1 is a marker of the average exposure to sugar levels over 3 months. 24 hours a day over 3 months. So that's the thing that matters the most. And it's the marker that best predicts eye disease, best predicts heart disease in diabetes if you get diabetes. They're miles away from diabetes. Just double check that that's accurate. Just non-fasting, forget the fasting. Double check the hemoglobin A1 is accurate, and then if it is, then be reassured. And I suspect Ali is relatively lean, and then forget about doing fasting glucose. And even the fasting glucose is completely normal. It's well below 7, so don't. Hemoglobin A1, keep doing, yeah.
Thanks, Naveed. I think Ali will find that very reassuring. To close, what's one thing that you'd like our listeners to take away from this conversation today?
There's a couple. One is that we have realised that it's getting harder to maintain a healthy lifestyle because of the environment. Do the best you can. Try and learn some simple tips that you can. Choose one goal. Maybe just one simple tip would be, for me, is try and eat more salad with your main meal would be my major tip, and walk an extra 500 steps, right? And you can get to a point where you start to enjoy salad. Trust me, or eating fruit. It just takes a bit of pressure to retrain the palate. And the other big thing is, for health professionals and all of us, and for governments, and we're all starting to realise this, obesity is the major driver of type 2 diabetes by far. It's ectopic fat. Yeah, we have different susceptibilities, but more weight goes up, the obesity prevalence goes up, we will see more diabetes. As night follows day, diabetes follows obesity. And it's the obesity that's the major driver, not only of the sugar, but many other the risk factors that also lead to the other complications. So we're moving towards tackling obesity probably first and foremost in diabetes beyond any other condition with the new drugs, which is what we want to do to help more people and have less suffering. But in the future, the big picture is hopefully we can change the environment so future generations don't need these drugs in 4 or 5 generations. But it's going to be a long journey. Yeah. So that's the one thing. Let's remove the stigma about obesity. Let's try and help people in the best possible way, explain things in the best possible way, and really have advocacy to change the food environment and policy. That's the direction of travel. And that hopefully is an optimistic viewpoint in the future. Let's see.
Thanks so much, Naveed. Really appreciate you sharing your expertise.
Thank you.
Absolute pleasure.
Charlie, hit me with your key takeaways.
Oh, I thought you were going to say hit me with your rhythm stick. That as well as my key takeaways. What were my key takeaways from today? I probably didn't realise how much genetics played such a part in type 2 diabetes. That was quite interesting. And the differences between my chance of getting diabetes as a 35-year-old female versus Naveed's as a nearly 60 South Asian male. Really actually quite surprised about those stats. What about yours? What are your takeaways from today?
One of them is that he really emphasizes the importance of ectopic fat.
Yeah.
Much more so than insulin resistance, which traditionally most people discuss. Another is just that body fat is such a huge factor. Mm-hmm. And it's amazing how when people lose it, their risk of diabetes goes down.
Yeah.
And just to give an example of this, there's a program, the Diabetes Prevention Program, very widely cited study that found that for every 1 kilogram of weight that people lost, there was a 16% lower risk of going on to develop type 2 diabetes.
16% for 1 kilogram?
Yeah, for every kilo. Yeah. And I wonder with these new medications, how the landscape is going to shift over time. In the US, for example, obesity has actually started declining, but it's carried on rising globally just because most of us don't have access to these medications. So hopefully, if prices carry on coming down, they get in the hands of more people that need them, we'll start to see a shift. And based on the data so far, it seems like the numbers of people with type 2 diabetes, or the proportions of people with type 2 diabetes, will potentially drop dramatically. So fingers crossed.
Amazing. You've been listening to The Method, Health in the Real World, a podcast brought to you by Thriver.
If you don't know about Thriver, it's a health tracking platform that helps you see where your health is heading and what to work on, as well as how to do it. They use painless at-home blood testing to look inside your body and see what's going on. Your tests are analysed by accredited labs, and based on the results, which are reviewed by doctors, you get personalised guidance from real people. People use Thriver like a compass, testing every few months to help steer their health to where they'd like it to be. It's a great tool to start feeling more empowered about your health and to get information that you need to make progress, even when life is chaotic.
Thriver also has some great content out there that can help you get to grips with complex health questions, exactly like what we're trying to do on this podcast. And all of that is free to access. So if you want to learn more, head over to thriver.co. That's thriver.co.
And if you want to listen to Charlie sing really, really well, subscribe to the show. Come back every week for more tunes. You won't be disappointed?
Well, unless you beg me to stop, but even then, probably not.
You can find us by email at themethod@thriver.co.
Seriously, we'd love to hear all of your questions. And your voice. We love a voice note.
Special thanks to the Thriver team and to Lower Street for helping us bring the show to life. Content direction by Rich Cousins, Hamish Grierson, Tamar Loach, Vishal Shah, and Katie Yockey. Production by our resident yogi, Lise Lavati, as well as Ryan Sutton and Sam Dattapoulin. Sound design by Alex Rose.
We're your hosts, Charlie Edmondson and Greg Potter, and we will see you next time.
Thanks and bye.
How are you?
Very well. Yeah,
Well,
that's it.
Great. I'm so glad we've had such a debrief on what you've been up to in the last 3 weeks. Yes, I'm good.
Yeah, that's all you're getting.
Excellent. Cool.
I'm good.
Moving on.
Yeah.